From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to this JAMA Clinical Reviews podcast. I'm Dr. Anita Cappola, Associate Editor at JAMA. My guest today is Dr. Anita Courcoulas, Chief of the Division of Minimally Invasive Bariatric and General Surgery, Anthony M. Harrison, MD, Chair in Surgery, and Co-Director of the University of Pittsburgh Surgical Outcomes Research Center, PittSource, all at the University of Pittsburgh Medical Center. Dr. Courcoulas is here to talk about her new manuscript, Long-Term Outcomes of Medical Management versus Bariatric Surgery in Type 2 Diabetes. Thank you for joining me on the podcast today, Anita.
A pleasure to be here. Thank you.
Can you tell us how your study was designed and what questions you sought to answer?
Yes, this study, it's a pooled analysis from 4 single-center randomized trials in the U.S. that were carried out between 2007 and 2013. The study's pooled observational annual follow-up continued through July of 2022. Originally, each of the 4 studies were designed to address a high-priority comparative effectiveness question. What's the best treatment for type 2 diabetes in the setting of obesity? Is it best available medical management or bariatric surgery? So each started as kind of a unique and relatively small feasibility study to help plan a much larger study. But when it became clear that a larger study was impractical and very costly, the 4 studies were then merged and pooled into this consortium. So for the study, at each of these 4 sites, the Cleveland Clinic, Joslin Diabetes Center, Brigham and Women's Hospital, the University of Pittsburgh, and the University of Washington Kaiser Permanente, Washington, people were originally randomized to either medical or lifestyle management that was intensive and modeled after the Diabetes Prevention Program and the Look Ahead study, or randomized to one of 3 bariatric surgical procedures, the Roux-en-Y gastric bypass, the sleeve gastrectomy, or the adjustable gastric banding.
What were the questions that you were trying to answer by pooling these 4 studies?
We were looking to see the efficacy, durability, and safety of bariatric surgery compared to medical and lifestyle treatment for people with type 2 diabetes and obesity.
And what was your main outcome?
The main outcome for this study was impact on change in hemoglobin A1C and other measures of glycemic control. And then secondary outcomes included cholesterol, blood pressure, change in weight, and adverse outcomes.
Could you please summarize what you found?
Overall, at 7 and 12 years of follow-up, people who were randomized to bariatric surgery compared to medical or lifestyle intervention had superior glycemic control with less diabetes medication usage and higher rates of diabetes remission. So more specifically, when you look at 7 years, the surgery group had greater improvements in hemoglobin A1C compared to the medical lifestyle group. The between-group difference at 7 years was 1.4%, and it was 1.1% at 12 years. And then when we looked at the threshold of A1C below 7%, and we compared the surgery to the medical group, 54% of the people in the surgery group achieved that threshold, compared to 27% in the medical and lifestyle group. And for diabetes remission, which was defined in this study as a hemoglobin A1C less than 6.5 off of all medications for at least 3 months, at 7 years, 18% of the people in the surgery group compared to 6% in the medical group achieved remission. The percent of people using medications to treat their diabetes also decreased in the surgery group from 98% at the beginning of the study on medications to 61% at 7 years in the surgery group, but the use of medications remained unchanged in the medical group over time. The surgery group experienced an average of 20% of initial weight loss compared to 8% in the medical lifestyle group at 7 years, and that was durable to 12 years as well. We also showed that surgery was more effective in improving HDL and triglyceride levels at both 7 years and 12 years after surgery. So these results and the differences between groups remain significant at 12 years In an exploratory analysis, results for hemoglobin A1C were also similar when we looked at people with class 1 obesity, a body mass index below 35, and compared them to everyone else who had a body mass index of over 35. So the results held up in these exploratory analyses for A1C in the lower BMI group. Finally, when we looked at adverse outcomes, there were no differences in major adverse outcomes between groups at 12 years. But there were more fractures, anemia and low iron, and more gastrointestinal events, things like nausea, vomiting, abdominal pain, and dumping syndrome in the surgery group.
Can we go back to the BMI findings for a minute? Because that's something that comes up, I think, a fair amount in terms of what are the right BMI cutoffs to use or what can be done? Can you still see improvement even in those with the lower BMI range? So you mentioned the stratification looking at those who had a BMI of less than 35. How low were those BMIs? Was it just the diabetes comorbidity, of other comorbidities to qualify for it, or was it simply diabetes and having that BMI for qualifying?
So in the original trials, people obviously had to have documented diabetes, and they were included in the trial with a BMI of 27 or over. What we're calling the lower BMI group for this study were people that specifically had a BMI between 27 and 34. So they included technically overweight and class 1 obesity, and that's the subgroup that we compared in this exploratory analysis to the larger group with BMIs over 35. So the qualifying factor for surgery was having type 2 diabetes, and then we stratified based on class of obesity.
Can we also talk about crossovers? So patients who were originally randomized to the lifestyle therapy, there were some that ended up going ahead and getting bariatric surgery. Can you talk about how many they were and how they potentially impacted the findings?
Yes, so there were a number of crossovers from the medical treatment arm to the bariatric surgery arm. In fact, 24 people, so 25% of the medical and lifestyle group over the course of the study crossed over and underwent bariatric surgery.
We're hearing more and more about medications to treat obesity and diabetes at the same time, but not as much about new trials exclusively looking at bariatric surgery. Can you talk about why it's important to look at a long-term outcome bariatric surgery analysis right now?
This is the largest pooled analysis with the longest follow-up of 12 years to date. And these results provide really important evidence about the long-term effectiveness and safety of bariatric surgery. And I think these results suggest that people who are overweight or have obesity and type 2 diabetes, they can make really important, measurable, and durable improvements in their health with bariatric surgery, with the long-term risks that we see quantified and outlined in this study. So these results, combined with existing evidence, do support the use of bariatric surgery for the treatment of type 2 diabetes for people with obesity. And they support some of the newer guidelines and indications that were published in the last couple of years from both the Diabetes Surgery Summit and Joint International Surgical Societies, which say that one should consider the use of bariatric surgery even among people with class 1 obesity if they have inadequately controlled diabetes. So I think in the context of the sort of exponential growth and use of these new GLP-1 agonist medications, I think what we can say from this study is that here we have high quality, long-term data showing the durability and safety of bariatric surgery. And I think other treatments that come to light, like the medications, are going to have to undergo similar long-term studies that look at long-term adverse events, look at the impact of coming off the medication, and then also address some of the issues relative to the new medications, which are cost and availability.
Were there any surprises in what you found in your study?
So I would have to say that there was not a true surprise, but I'll maybe use that as an opportunity to raise an issue that I think is important to note. While the surgical group had better diabetes remission than the medical group, within the surgery group, diabetes remission does decline over time. Yet, even when relapse occurs, the participants in the surgical group still experience better glycemic control on fewer medications than the medical group. So I think the take-home point there is that we have to continue to surveil patients for life for relapse and potential other complications. But another important point here is that there is sort of a legacy effect of experiencing a period of remission, even if it's short term. And other studies have shown that that may lead to a decreased incidence of microvascular disease. And then a second point that your question allows me to raise is that although this study wasn't really powered to make comparisons about adverse outcomes, it's also going to be important that we surveil patients undergoing these treatments, including bariatric surgery, to monitor for adverse events, micronutrient adverse events, and others over time.
Who should your study be generalized to? And I'm going to focus particularly on the duration of diabetes that someone may have before they undergo bariatric surgery, when specifically we're thinking about remission from diabetes.
So I think we can generalize the results of this study to adults with all classes of obesity who have type 2 diabetes. But it's important to note that people in this study had relatively poorly controlled diabetes. The average A1C at the time of entry into study across the whole study was 8.5, and the mean duration of diabetes was 8 years. So in general, the people in our study had long-standing and suboptimally controlled diabetes. So I think the results of this study can be generalized to that group. In addition, because it was a 4-site study, it's kind of geographically diverse. And we also included the 3 most common operations done in bariatric surgery, because bariatric procedures themselves have undergone a fairly significant procedure shift. When the study started, the laparoscopic adjustable gastric banding was a common procedure, but now the sleeve gastrectomy is the most common procedure performed in the United States and around the world.
Now, I know it was a sub-analysis, but you did look across the different types of procedures. Maybe you had enough power to do it, or maybe you didn't, but did you see differences in terms of the effects of bariatric surgery, not just the differences in the adverse effects, but benefits as well as the risks? Can you talk about those across the procedures that are currently being used?
So between procedure comparisons are really interesting and important. This study was not powered to look at those, but we did look at them in an exploratory analysis. And the big picture summary of the comparative results is that the gastric bypass performs the best in terms of glycemic control and weight loss and other outcomes, followed pretty closely by the gastric sleeve. And then the gastric band is the least effective of the 3 procedures. And that's one of the reasons why the gastric band is not being currently used commonly, that and the fact that it has to be removed for intolerance. So I think we showed in this study in exploratory analyses that in terms of effectiveness for our outcomes, bypass, sleeve, and then banding.
You mentioned what the differences were across the different procedures in the benefits in terms of weight loss. Can you speak about the differences in the procedures in terms of risk as well?
So interestingly enough, one of the little surprises of this study is that there were not a large number of serious adverse events following either treatment, surgical or medical. So the numbers were really too small to make any between procedure comparisons. Other studies have done that, and they show that gastric bypass has more short and long-term complications compared to gastric sleeve or gastric banding. But in this study, the number of adverse events were relatively low, so we could not make meaningful comparisons between the procedures.
What limitations in the study do we need to consider as we're interpreting it?
So I think we made a thorough list of the limitations. This is a pooled study of 4 different trials. So there were differences in the original trial protocols, and some of the treatments were not identical across studies. So that's certainly a limitation. So a pooled analysis like this could create bias or a form of confounding that's induced by the original trials. We also note that there could have been selective dropout over time in the medical lifestyle group, because you can't drop out of surgery. So someone who was doing better from a health perspective may have stayed in the study longer. Again, because of 4 different trials merging, there were different enrollment timelines and different lengths of follow-up. In addition, as I've already alluded to, we were not powered to detect differences between the 3 surgical procedures or to look at the risk of major adverse outcomes or mortality. And then finally, we also acknowledge that there was the increased use of incretin and GLP-1 medications that occurred in parallel in both groups during the follow-up period of this study. So changes in the use of this class of medication over time could have influenced between group differences in outcomes.
Let's go back to the clinical impact of your findings. And the way I want to frame this is that you have a patient in front of you who has both obesity and diabetes, who is thinking about next steps for therapy. In the past, we were able to offer lifestyle management, and there was a limited palette of medications as well as bariatric surgery. And now we have a much wider suite of medications out there, including the GLP-1 receptor agonists and all of their other permutations. When thinking about a patient, can you talk about what would be some of the factors that would guide moving towards bariatric surgery?
The way I look at these study results is that this is the definitive long-term study comparing medical management to bariatric surgery. And it shows that bariatric surgery is superior for glycemic control, diabetes remission, weight loss, improvement in some aspects of cholesterol. So I think patients can now at least be presented with the best available long-term data that shows the effectiveness and safety of bariatric surgery. And that will help guide a shared decision-making conversation about this new set of GLP-1 agonist medications, because they are in an earlier phase of development and building the literature that bariatric surgery was in 15 to 20 years ago. So it's exciting that these medications are leading to degrees of weight loss that approach bariatric surgery, but it appears that patients have to remain on the medications, perhaps for life, and that when they come off medications, they may regain weight above where they started, and that long-term adverse outcomes with the medications have not been yet carefully outlined, and that's going to take a number of years. And then I think a third area in talking about the new medications is that we do have to address the cost. They're not currently covered by most major insurances for at least the treatment of weight and obesity, and there's been some issues with availability of medications. So I think this study is kind of timely in that it culminates, I think, a body of literature in surgery trying to compare surgery to medical treatment, and now we have this whole set of new medications that work by new mechanisms that appear to be more effective, but they are still a little too early in their long-term results to be able to make head-to-head comparisons.
I'd like to ask about patients who may have tried the GLP-1 receptor agonist therapies first. Either they didn't tolerate it, they lost some weight but don't want to stay on it, and then would consider bariatric surgery. Now, I understand that there aren't the studies to exactly show you that, but what are some of the concerns or advantages to being on one of those therapies first and then going to bariatric surgery?
Right now in clinical practice, we're seeing two groups of patients on the GLP-1 agonists. One group are the people who are experiencing the side effects, mostly gastrointestinal, and find the medications not tolerable. So they may then consider a surgical approach. Other patients have been on the GLP-1 medications for a year or longer, have experienced good weight loss in the 20% range or greater, but have decided that they don't want to remain on medications for life. So they may then look at considering surgery at that point in time. And one thing to think about in patients that are on GLP-1 agonists that consider undergoing bariatric surgery or, quite frankly, any other general anesthetic is that because GLP-1 agonists act by inducing gastroparesis, patients have to come off of their medication for several weeks prior to undergoing general anesthesia to avoid aspiration risk.
Is there anything known about the efficacy of the surgery after being on one of these medications? Is it the same as if you're naive to it, or is the surgery just as good?
Patients are asking that question every day, and I don't think we know the answer. I wonder whether or not being on a GLP-1 agonist prior to undergoing bariatric surgery may in some way sort of lessen the impact of bariatric surgery, which also in part works by acting on the GLP-1 axis. So I think future studies are going to have to help us understand if being on a GLP-1 agonist before bariatric surgery accentuates or reduces your total weight loss and metabolic results with a bariatric operation.
Now, I have a question about a different patient, one that maybe was naive to a GLP-1 agonist, undergoes bariatric surgery, and then wants to start it after surgery, either because they've had a plateau in their weight loss, they've had some regain afterwards, and they want to then try it at that point. What is known about that sequence of procedure and then GLP-1 agonist therapy?
considering the use of a GLP-1 agonist as an additional tool for bariatric patients who may plateau with their weight loss too early or who may achieve good weight loss results but then regain weight, I think that may be an excellent opportunity to use these GLP-1 agonists. And patients are asking about this before surgery so that we can then actively monitor their weight loss trajectory after surgery. Most patients will achieve the majority of their weight loss with bariatric surgery within the first 12 to 18 months, and then most have plateaued by year 2 or 3. So these new agents, these new pharmacologic agents may be important in helping to optimize the results with bariatric surgery. Because when you look across the board at bariatric surgery, the problem of inadequate weight loss and weight regain does affect about 15 to 20% of patients.
I want to go back to something, and that is making sure that we're comparing the studies with the GLP-1 agonists to bariatric surgery appropriately in patients who have type 2 diabetes. And to highlight that the studies that are out there that are in patients who are looking for it for weight loss but don't have diabetes, as opposed to patients who have diabetes, the amount of weight loss that is seen with these agents in patients with diabetes is not the same as those without. And so that's something I just want to highlight, and maybe you can add anything on to that. This study was done in patients with diabetes who also had a degree of obesity. And you're looking at both the effect on the diabetes as well as the weight loss. And the focus of these medications recently has been about the weight loss, but we need to bring it back to the diabetes remission as one of the important complications of obesity as well. And I just want to make sure people are comparing things appropriately. And I don't know if you want to add on to that at all.
No, I mean, I agree wholeheartedly. Our study was done only in people that had type 2 diabetes and obesity. So here we're just looking at people that have both. But in terms of the medications, you're absolutely right. People with diabetes on GLP-1 agonists lose less weight than people who don't have diabetes. There's also important differences based upon gender as well. In most of the studies, women with the GLP-1 agonists do better with weight loss compared to men. So I think it's important that we take that into account when we're comparing those results.
Well, thank you. This is a chance for any final thoughts, anything that we didn't cover that you might want to mention about your study.
A really important part of this study is that this was a true group effort across 4 sites with study staff and investigators at each of the sites, all of whom contributed greatly to this study. As well, the participants in this study across all sites were really highly engaged and generous to this study in both their time and their participation.
Well, thanks to Dr. Anita Courcoulas for joining me today to discuss long-term outcomes of medical management versus bariatric surgery in type 2 diabetes. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.